All right, so good evening, everyone. We're going to get started. And we have also, I think, people joining online. So we look forward to our grand rounds today. Uh, I'm going to just go ahead quickly with the slides to introduce the CMA and MOC. Uh, this is the website for all the grand rounds. Dr. Carson's grand rounds will also be staying hosted on the website. And for getting CME credit for the session, please text 20409 to number 888-816-4893. You can visit over the next 12 hours and get the credits. And for getting the MOC points, revisit the step one, and this link would be available with a future code, room code of future 2024. So please look forward to this also announcements going on during the session. So both sessions will provide you with the link, and you'll be able to take the questions and then answer them and get your MOC credits as well. With that, it's a great honor and privilege to welcome our provost, Dr. Carson, who is a distinguished professor of medicine. And I had a great day with Dr. Carson. We had our trainees and junior faculty all who spent time, and we really learned how his mind thinks, and what he gave us were really valuable tips on how we could distinguish ourselves in the challenging current environment where we have an opportunity to do academic careers, or even if we are in the clinical track, have a chance to be associated with research in many ways. Dr. Carson went for his internal medicine residency at Hahnemann Medical College, Pennsylvania. He also had a research fellowship and subsequently joined UMDNJ in 1982 as assistant professor, and then he rose in the ranks there and became the chief of the Division of Internal Medicine in 1987. Subsequently, he was the vice chair of research at the department and became provost for our university in 2014. He also emphasized the importance of research training. So he had taken a sabbatical and gone for Fogarty's senior fellowship, research fellowship at the University of Oxford, 1995-1996. And ever since then, he has been a world-renowned authority in red blood cells transfusion and clinical trials related to it. He has made some significant landmark trial contributions, and he has been funded extensively from NHLBI for his research. One of his trials, which was called as Focus, was featured as 34 key trials for NHLBI and was published in NEGM. And more recently, the MINT trial was published. He has had a distinguished career with a track record of funding from NHLBI over the last 2 decades. And he has contributed to monumental research works in forms of over 150 research papers in extremely high impact journals, monographs, over 35 monographs and editorials and chapters. And more importantly, he has also shaped the future of trainees and researchers by being associated with several committees in NIH and NHLBI. He was the chair of a study section at NIH on clinical trials. And I was very fortunate because when very recently, for one of my study, when I had some difficulty responding to the reviewers, I went back to him asking for some impressions, and he was so immediately ready to help and jump in and provided really a great guidance. And that really sparked me to get him connected to the division, because I think the division will really learn from how we could be training the next generation of leaders. And I'm really looking forward to the journey from here onwards. With that, we are looking forward to your talk, Dr. Carson, on RBC transfusion thresholds in cardiac patients. And joining for the panel later on we'll have Dr. Wang and Dr. Costas for the panel discussion. Thank you, Dr. Costas.
All right. Hey, you can hear me all right? Do I need this thing or I can wander? You can hear me okay? Yeah, I got a big mouth. So let's see here. Does this work? Yeah, great. All right. It's really nice to see you. And I really enjoyed this afternoon, meeting many of you. I hope it was useful. And it was useful for me because I got to see what's going on in cardiology. And there's been a lot of progress. And congratulations to Partho and to all of you for all the effort. I don't have any of the usual conflicts of interest where we usually talk about pharmaceutical company conflicts, but I think this is a conflict because this is my work that's funded by the NIH, and so I think you have to keep in mind that the investigators have skin in this game, if you will, and they have different perspectives. So what I want to do today is briefly go over the risks of transfusion, and then I will talk about the risks of anemia. So when you weigh deciding whether to give blood, you're going to deal with the risks of transfusion, the risks of anemia, and then we're going to try to figure out if blood makes a difference. And I'm going to focus in on the clinical trials and then go through some guidelines that we published recently in JAMA and then summarize for you. So I always like to start with cases to engage the audience and to see how many of you have injuries to your shoulders that make it impossible for you to raise your hand, and which my experience is that this is often a problem in my audiences here. But we're going to engage. Since I now know who you are, I'm going to come up and call on you if I don't see any responses. Okay. So the first case, a 68-year-old patient with a history of COPD develops increasing dyspnea. It's a woman. She has a pneumonia on her x-rays, is transferred to the MICU, intubated, treated with antibiotics. Over the next few days, the hemoglobin drops from 11 to 8.5. Patient's euvolemic, blood pressure is stable. So is anyone giving blood to this patient at 8.5, 68-year-old person who's getting pretty young in my eyes these days, as you might imagine, huh? Right, Abel? Pretty young, huh? Anyone? No one's giving blood at 8.5. Who's giving blood at 8? Anyone giving blood at 8? No. Who's giving blood at 7? Okay, the hands went promptly up. Anyone waiting till 6? I have audiences that I can never get them to raise a hand at all because they never want to give blood. Okay, so you're a 7 audience in the ICU. Now, what about an 80-year-old woman who's 2 days post-op from a hip fracture repair? History is significant for hypertension, diabetes, and a history of MI 3 years ago. Post-op is a little tired and weak. Exam is clean. Hemoglobin's 8.5. So we got an 80-year-old person who's got lots of underlying cardiovascular disease. Are you giving blood at 8.5? Anyone giving blood at 8.5? No. Who's going to give blood at 8? 1. Who's going to give blood at 7? Okay, we're going to 7, this group. Any 6s? No. Okay. Third case is a 66-year-old guy falls into your wheelhouse here, right? With chest pain in the ER, EKG shows a STEMI. Patient's taken the cath lab. Mike Wong slips that stent into the LAD. Admission hemoglobin's 10.1. And the following day, the hemoglobin drops to 8.5. It's not because of a hematoma from the cath, but rather this patient GI bled, has a melanotic stool, vitals are normal. Would you give this patient blood at 8.5 who's just had a STEMI? Any hands up? We have 1. Who's going to wait till, we have 2. Who's going to wait till 8? Okay, anyone waiting till 7? You haven't raised your hand. Where are you giving blood? At what? At what number? Less than 8, at 7.9. Oh, I see. So you wouldn't give 8. Okay, thank you for that that point of clarification. I appreciate that. All right. So we're going to come back to these cases, and I'm going to show you the evidence in terms of what I think you should consider doing. So we go to the bedside. We're thinking about, should we give blood? And we're weighing the risks and the benefits. The risk side of the equation is the side effects of blood and the risks related to anemia. And if you decide to give blood, you're hoping that it may favorably influence mortality, morbidity, or functional recovery, the ability to take care of themselves do activities of daily living, for example. So let's look at the side effects of allogeneic blood. And one way you can organize this is that every single patient causes a problem, all the way down to a rate of 1 in 100 million. So if we look at the common stuff that we talk about that your patients are going to ask you about, well, what's my risk of getting HIV, Hep C, hepatitis B, having a fatal hemolysis? The answer is less than 1 million. Okay, these are all really, really uncommon. They're not clinically significant. Okay, they're just too rare. Fever is common, but so what? We can deal with that. Okay, but side effects that are a little bit more common and perhaps clinically more relevant are what's called TACO, trolley, and then there's some life-threatening reactions. So what is trolley? Trolley is basically an acute ARDS type reaction, acute lung injury associated with bilateral infiltrates. You're trying to exclude that the patient's in heart failure. It typically occurs within 6 hours, but is early, commonly at 2 hours with any blood product. The patient can look like they're infected with chills, fever, they're dyspneic, cyanotic, blood pressure can be up and down, and it can happen with any red cell, any blood product. Now, a much more common thing is what you guys deal with every day. And the transfusion community likes to make up their own names. They call it transfusion-associated circulatory overload, TACO. It's heart failure. I don't know why the hell we have to have our own name. It's heart failure. It's volume overload from blood. It frequently reports somewhere between 1% and 3% in the reports, but it really depends on how the volume status is managed in those patients, of course. And it's certainly common, clinically important. And you guys certainly know how to deal with this illness. So another side effect that's talked about a lot in the literature is when you give blood and you measure immune function, you will see a change in immune function in vitro. But what matters, of course, is how does it affect clinical infections? And this comes from our Cochrane systematic review, where we looked at the risk of infections in those who got less blood compared to more blood. No difference at all. So it appears that while you can measure stuff in the lab, it doesn't translate into clinical events. So no association with infection. Now, I always like to think about as a control group. As an epidemiologist, I say, well, how does these risks compare to everyday risks? Well, let's see here. If you drove to work here in New Brunswick, New Jersey, okay, your risk of dying from a car accident is about the same as getting trolley. And what about getting shot? Okay, well, it's not so bad in New Brunswick. If you have this talk in Newark, you might have a little different sense about the concerns there, okay? But it's somewhere in the range of life-threatening reactions. These are real numbers, not made-up numbers. Your risk of dying in a plane accident, if you go to a third world country with lower quality, not Western style airplanes, your risk of dying in an airplane accident is the same as getting HIV and Hep C. And your risk of getting hit by lightning, real numbers. This is not me blowing smoke here. If you live in the plain states, your risk of getting hit by lightning is the same as getting HIV or Hep C from a unit of blood. Kind of cool. It's real numbers. If you live in this part of the world, well, you got all these tall buildings that take care of that lightning, so it's not such an issue. So to summarize this part of the talk, the risk of HIV and Hep C is very low. Trolley is an important serious side effect, but TACO is much more common. And the risk of blood from known problems is very low and comparable to everyday risks. So what's the take home? The take home is, when considering whether to transfuse a patient, it is not about risk. The risk is low. Rather, it's about whether the stuff works. What's the efficacy? Does it improve clinical outcomes? Of course, there's cost, and blood's a finite resource. It's not always available. So these are certainly important issues, but it's really not about risk. And many who talk about this subject always focus on the risk. It's, in my view, it's clearly not about that. All right. So what about the risks of anemia? Okay, what happens when patients are anemic? When do you run into trouble? So this is the results of a paper we published in Lancet way back in 1996. It's my first NIH grant. This is a cohort study of patients who declined blood for religious reasons. So these are patients of the Jehovah's Witness faith. We looked at our primary outcome was 30-day mortality and then we also looked at morbidity. Cardiovascular disease in this analysis was defined as patients with a history of MI, angina, heart failure, peripheral vascular disease. And we had nearly 2,000 patients who underwent a surgical procedure in an operating room who were 18 years of age or older. We had nearly 2,000 patients in this trial. We had and here are the preoperative hemoglobins, the numbers of patients in each group, the proportion who died with their confidence intervals. So if you go to the bottom here, most of the patients had normal or near normal hemoglobins pre-op and very low mortalities at 30 days. But as that preoperative hemoglobin falls, there's a roughly linear relationship between the risk of that preoperative hemoglobin and death at 30 days. But the real interesting finding in this, and I think the reason the Lancet took it, is that here you can see we plotted the preoperative hemoglobin by the adjusted odds of death. Here in blue are patients without cardiovascular disease. Here in red are patients with cardiovascular disease. And what this curve says is in patients with cardiovascular disease, the odds of death rises much more rapidly than patients without cardiovascular disease. And it actually takes off at the often criticized 10-gram threshold. And these two curves are statistically significant. That's what the test for interaction says. Now, we also looked at the same cohort of patients, but we've sliced the data a little bit different. We said, well, let's look at patients with post-op hemoglobins less than 8 and see what happens to them. So there's about 300 of those patients in this cohort. And you can see patients with post-op hemoglobins between 7 and 8, their risk of death was extremely low. And at between 5 and 7 is around a 9% risk of death in this group. But below 5, not good, okay? Death starts to rise pretty rapidly, and these patients don't do well. So a clinical point that is unrelated specifically to this talk, when you're taking care of the Jehovah's Witness community, you don't want them getting below 5. And it means you better intervene earlier, right? You don't want to let them go there. This is what the data would strongly suggest. So I conclude here that mortality and morbidity rises as the hemoglobin falls, and that human data suggests that patients with cardiovascular disease may be less tolerant of anemia than patients without cardiovascular disease. Now, let's be clear what I haven't shown you. I've shown you a risk. It could be, how do you get so low? Well, you're sick. You got a lot of other things going on here. You need to demonstrate that blood transfusion modifies that risk. All you can say is that the risk seems to go up based on this data. So we need clinical trial evidence to try to clarify that point. So here's a slide that you can't read. This comes from our Cochrane systematic review, which was published in 21, in which we list all the trials. Okay, and these trials, and unfortunately, this thing is all blocking it. On one side are patients who got less blood, which we call restrictive transfusion, and the other column is patients who got more blood, which we call liberal transfusion. Okay, and what we are looking at is what proportion of reduction of blood use does that result in? Well, it reduces, if you got randomized to the group that got less blood, you got about 40% less blood if you've been randomized to a restrictive group. That's all this says. That's what this analysis says, and it lists the different trials. But the question, of course, is how does it affect outcome? So let's go through the key trials in the field and give you a sense for what's been done, and then I will summarize what it looks like. So the first classic trial was performed by Paul Hebert, called the TRICK trial, published way back in 1999. This is an original trial in the field. He took clinical consecutive ICU patients with hemoglobins less than 9 who were euvolemic. They were in the unit. They randomly allocated them to a restrictive group, which was a 7-gram threshold, and maintained a hemoglobin between 7 and 9. In the liberal group, patients were transfused if the hemoglobin was less than 10 and maintained between 10 and 12. So this is a 10 versus 7 trial, okay, and the primary outcome was all-cause mortality. They had about 800 patients in this trial. In the group that got less blood, the mortality was 18.7%. In the group that got more blood, the mortality was 23%. Not statistically significant, but keep in mind in all these trials, if you're going to use more blood, you need to demonstrate that it is superior, that it improves outcome. If they're comparable, you should use less blood. You're avoiding any kind of small risk associated with it. You're saving resources. Okay. So while this study did not demonstrate more blood was superior, it certainly, inferior, it certainly didn't suggest that there was benefit from it. Second trial. This is my trial, which was published in the New England Journal in December of 11. We called this the FOCUS trial. In this trial, we randomized patients with hip fractures with underlying cardiovascular disease or risk factors, hemoglobin's less than 10. Our liberal group was a 10-gram threshold. Our restrictive group was an 8-gram or symptoms. I always incorporate symptoms into all my trials. So if a patient has symptoms, we throw out the hemoglobin threshold and we follow the patient's symptoms. It turns out it doesn't come up very much in real life. And we looked at function, mortality, recurrent MI, and morbidity. And we had 2,000 patients or so from 47 centers in the US and Canada. And this was funded by the NIH. Okay, we had about 1,000 patients in each arm. Our primary outcome was not walking or dead at 60 days. We also looked at 30 days. So none of you need to be fancy statisticians to see that 35% versus 34% or 46 versus 48%, that there's nothing there, and that patients did not benefit from a functional perspective with using more blood in this hip fracture elderly group of patients. We looked at mortality in different time periods, both in hospital at 60 days, and then we followed these patients up to 5 years. And this was published in The Lancet in 2015. You can see these curves are essentially overlapping curves with a hazards ratio, which was not significant. So no influence on short-term or long-term mortality as well. The third trial to tell you about is a trial in GI bleeding patients. This was performed by a gastroenterologist from Barcelona. They took adults with hematemesis or melanoma. They excluded anyone who was exsanguinating. Anyone who had heart disease is not in this trial. So this trial does not refer to patients with heart disease. The restrictive group was transfused at 7, the liberal group at 9. In both groups at the time of randomization, they were given 1 unit immediately. And then they have an odd time period of death at 45 days as their primary event. And here you can see the Kaplan-Meier curves here. If you go from 0 to 100, you can see they look pretty much the same. But if you blow it up, what you can see here is that this is the only trial that has shown that the liberal transfusion strategy was associated with a higher mortality than the restrictive, and it was statistically significant. So if we can look at this in a different way, the absolute difference is is about 4%, with the restrictive having the primary outcome of all-cause mortality at 5% versus liberal at 9%. This was statistically significant, so an absolute difference of 4%. Now, the question, of course, is why would they die more frequently? Well, it turns out, if you look at recurrent bleeding here, that the patients in the liberal group rebled 16% versus 10%. So the theory is, and I think there's evidence to support this, that you have a patient who bleeds, the clot forms over the hole in the blood vessel. You fill the tank with red cells, increase the intravascular volume, you blow that clot, they rebleed, and then they're more likely to die. And the other evidence is that they measured portal pressures in a subgroup of these patients, and the portal pressures were substantially higher in the liberal group than the restrictive group. So that may be the reason why in GI bleeders that patients seem to die more frequently in the liberal compared to the restrictive transfusion group. There was a little bit, by the way, a little more taco in the liberal group in this study as well. Okay, the last trial I want to show you, which is highly relevant to you guys, is a cardiac surgery trial. This was performed by David Mazur, who's an anesthesiologist from the University of Toronto. They call this the TRIX-3 trial. This was a trial in 5,200 adults undergoing cardiac surgery who had a Euro score of 6 or more. This basically is a score that says that these patients are more likely to require a red cell transfusion. The transfusion protocol was started from the induction of anesthesia. And the restrictive group used a 7.5 threshold. The liberal group was a 9.5 threshold when they were in the operating room or in the post-op ICU. When they went to the floors, they used an 8.5 threshold. All the patients in this trial got blood either in the operating room or ICU. The primary outcome was a composite of death from any cause, MI, stroke, new onset renal failure with dialysis by hospital discharge, or 28 days. So what did they find? Well, they found no difference, okay? That the composite in the restrictive group was 11.4. That's the first column here. And in the liberal group was 12.5, not significant. Death was not significant. Acute recurrent MI was not significant. So no benefit by liberal transfusion in cardiac surgery. There's other trials out there that show pretty much the same story. So those are illustrative trials that have been published up to the 21 time period. And we have been doing Cochrane systematic reviews and meta-analysis for a long time. This is probably the fourth or fifth version of this. It was published in 21. We're in the middle of updating it again right now. And so what is that data? So if you look at 30-day mortality, which is the primary outcome for this meta-analysis, there were 16,000 patients from 30 trials, which collected 30-day mortality. And look here, the relative risk is 1.00 with confidence intervals between 0.86 and 1.16. Very tight confidence intervals, okay? Showing no benefit or harm from liberal or restrictive transfusion strategy. Now, we also looked at lots of other morbidity outcomes from MI, heart failure, stroke, rebleeding, infection, clot, delirium. None of these results are statistically significant. Some trend a little bit favoring restrictive, such as stroke and rebleeding, heart failure. Others went the other direction, but no statistical significant differences between liberal and restrictive transfusion for those outcomes. So I would summarize, based on the clinical trial evidence I've shown you up to this point, is that liberal transfusion did not improve outcome or harm patients, and restrictive transfusion strategy did not improve outcome or harm patients. That's important because we tend to focus on, oh, blood can be harmful. Well, we're not seeing that, but we certainly would not use more blood unless we can show that we can improve outcome. All right. Now, I told you that this talk was going to be focused on cardiovascular disease patients. You guys are cardiologists, so that's, of course, what you're most interested in. So let me show you what evidence we have here. So we go back to the Jehovah's Witness study, in which I showed you we plotted preoperative hemoglobin by the odds of death. And here in red are patients with cardiovascular disease, and they appear to be at greater vulnerability of anemia than patients without cardiovascular disease. But the question, of course, is, does blood modify that risk? So we can go to the TRIX trial. This is the original Paul Hebert New England trial published in 1999. And the overall results, which I told you before, showed that, if anything, the restrictive group looked a little bit better than the liberal group, but not statistically significant. Well, they did a subgroup analysis published in Critical Care Medicine and in subgroup of patients with ischemic heart disease. And notice here that the curves flip, that the liberal group does a bit worse than the restrictive group, but it's only 300 patients. It's not statistically significant. And it's interesting, perhaps hypothesis generating, but that's all you can say from this data. So what about acute MI? Well, we've been studying acute MI for a while, and this is our pilot study. We call this trial MINT, myocardial ischemia and transfusion. And the pilot was funded by the NHLBI and published in the American Heart Journal in 2013. So what did we find? We randomly allocated those patients to a 10 versus 8 threshold, okay, in this trial. And group A, which had 55 patients, and group B had 54. Group A, our primary outcome in this pilot was death, MI, unscheduled revascularization, had an event rate of 10.9% compared to group B, which had a 25.9% rate. But what really catches your eye is, oh my, 1 death in group A and 7 deaths in group B. And even though this might not be statistically significant, it certainly raises significant concerns. So, my question for you, hands up, who thinks group A is restrictive transfusion? Who thinks group A is liberal transfusion? Who doesn't want to raise their hand? All right. And I'm not talking 7.9, it's 8. Sorry, man. But so what did we find? It turned out that the liberal group looked like they were doing a lot better than the restrictive group. And what I would tell you, and what I told people all along when we looked at these results of this trial, is you shouldn't trust these results. Now, why would I say that? It's my own work, right? Of course, it must be well done, but it may be well done, but it's a small trial. And small trials are notoriously unreliable and not reproducible. So I always taught that you should not base your clinical judgment, your clinical treatment on the results of the MINT pilot. But this was incredibly helpful in me getting funded for the big one, okay, for the 3,500 patient trial. And I would say, thank goodness for that. All right. So the second trial to show you in acute MI is called the Reality Trial. This was performed by Gabriel Steig, Tabasson Samo. The first author is Gregory Duquois. Okay, this is performed in France and Spain. They randomized patients with acute MI with hemoglobin between 7 and 10 to a liberal transfusion strategy, which was at 10, a restrictive, which was 8. Their primary outcome was 30-day MACE, defined as death, reinfarction, stroke, and emergency revascularization. And what they found was an event rate of 11% in the restrictive group and an event rate of 14% in the liberal group, confirming non-inferiority of restrictive transfusion. So that's where we were up until December of this year, in which we published the MINT trial in the New England Journal of Medicine, which I'm really proud about. So what did we do in MINT? We performed a trial. We enrolled patients from April 2017 to April 23. We had 144 sites in the US, Canada, France, Brazil, New Zealand, and Australia. You can see this on this map. The majority of patients were enrolled in the US, with 800 or so in Canada. Our French colleagues, which were the same group that did the Reality Trial, Gabriel and Tabasson, they were members of our leadership team, and they enrolled 300 more patients into the trial, 100 or so from Brazil, and a handful of cases from Australia and New Zealand. We enrolled patients who were 18 years of age or older, who had a STEMI or a non-STEMI, and type 1, type 2, 4B, and 4C, and we required a hemoglobin less than 10 within 24 hours of randomization. We excluded anyone with uncontrolled bleeding, receiving only palliative treatment, scheduled for cardiac surgery during that admission, and who declined blood for religious reasons. We randomly allocated patients to a restrictive transfusion group, in which transfusion was permitted but not required when the hemoglobin was less than 8, and strongly recommended when it was less than 7, or when anginal symptoms were not controlled with medications. In the liberal transfusion strategy, 1 unit of packed cells was administered following randomization, and blood was transfused to maintain a hemoglobin greater than 10 through hospital discharge for 30 days. Who did we enroll? We enrolled, the mean age of our population was 72. Almost half of them were women, which was great. 66% had multivessel disease, 82% had non-STEMIs, 42% had type 1. And note here, more than half had type 2 MIs in this trial. 14% were tubed and 12% were on dialysis, a very sick group of patients in this trial. The differences in blood use were quite substantial. In those in the restrictive group, the number of units given was 1,200 or so, or 0.7 units per patient. We gave 3.5-fold more blood in the liberal group and 2.5 units on average. So what did we find? Our primary outcome, as I said, was all-cause mortality or recurrent adjudicated myocardial infarction. Of the 1,749 patients in the restrictive group, 295 or 16.9% of these patients had our primary outcome of death or recurrent MI. And in the restrictive group, we found an event rate of 14.5% out of 255 out of 1755 patients. This yields a relative risk of 1.16, a lower confidence interval of 1.00, with upper confidence interval 1.35. But there were 57 patients in this trial that we did not have the primary outcome, that we had to impute their results. And this leads to a slightly lower relative risk of 1.15 and a lower confidence interval that overlaps 1 now at 0.99, yielding a p-value of chest-producing p-value of 0.07. So you can imagine what I might have said when I first saw these results. I could not professionally describe those 4-letter words. I used many of them at the time. Okay, so what else did we find in this results? Well, we had our secondary outcomes of death. The relative risk was 1.19. MI, the relative risk was 1.19. Death, MI, unscheduled revascularization, or readmission for cardiac reasons was 1.13. You can see here all these favor liberal as well, but the confidence intervals overlap 1. So we were certainly very concerned from a safety perspective of heart failure. We're giving volume to a group of patients who have a lot of LV dysfunction. And what did we find? Well, an event rate in the restrictive group of 5.8%, of 6.3% in the liberal group, about a 0.5% difference. Our cardiologists here and across the trial were able to manage their volume status quite well. And the most significant statistical finding that we had was for cardiac death, with an event rate of 5.5% in the restrictive group, 3.2% in the liberal group, yielding a relative risk of 1.7, which was highly statistically significant. I tell you that the cardiac death was not adjudicated, though. It was not adjudicated. So to summarize the results of MINT, the MINT trial did not demonstrate a statistically significant difference in the rate of 30-day death or recurrent MI with acute MI and anemia assigned to a restrictive compared to a liberal transfusion strategy. But while not statistically significant, the point estimates of the primary outcome and secondary outcomes consistently favored a liberal transfusion strategy. Heart failure and other safety outcomes were comparable in the 2 transfusion groups. So what are the clinical implications? There's more. The secondary outcomes consistently favored liberal transfusion, and the risk associated with liberal transfusion were not elevated. So we look at what's the absolute risk. Well, for the primary outcome was a 2.4%, and it yields a number needed to treat of 42. Okay, all-cause mortality, a difference of 1.6%, and number needed to treat of 63. We would argue that these differences are clinically important and comparable to many of the treatments that you use to manage patients with acute myocardial infarction. So in contrast to other clinical settings, the trial results suggest that a liberal transfusion strategy has the potential for clinical benefit with an acceptable risk of harm. And therefore, we think a liberal transfusion strategy may be the most prudent approach to transfusion in anemic patients with acute MI. Now, I should add 2 more things, which I guess these slides I'm missing. Is the first is that there were letters to the editor, okay? And most letters to the editor, when you publish in major journals like this, are critical. Well, these 2 letters of the editor, I wanted to give both of those authors a big hug because they were so supportive. Okay, the first what they called a fragility index, which showed that if you move 2 cases in the liberal group, in the trial, towards favoring the liberal group, you get a significant p-value, just 2 out of 3,500 patients. Oh my. Okay. And then they did a Bayesian analysis in which they said, we're going to look at what the pre-test probability is for for liberal transfusion or restrictive transfusion to be harmful. And what they showed was that if you assumed a low prior probability, you still had an over 90% likelihood that restrictive transfusion was harmful in these patients with acute MI. That's what they said in these letters to the editor, and I'm certainly happy to share those with you. So that's the data we have on clinical trials in acute MI and across the whole field. Now, we have been doing guidelines. This is the 3rd version of the guidelines that I chaired the AABB committee on this, and this was last published in just this past November in JAMA. What we did was we debated in these guidelines, give you a little bit of the backstory, is should we recommend in everyone a 7-gram threshold, or should we use different thresholds based on the clinical subgroups? The committee was made up of 22 people. The vote was 11 to 11, okay, splitting the difference as to whether you should use different thresholds or not. So ultimately, the guidelines read that for hospitalized adult patients who are hemodynamically stable, the international panel recommended a restrictive strategy considering transfusion when the hemoglobin is less than 7, but also based on the restrictive transfusion strategy used in most trials, clinicians may choose, and I should tell you, this is my point of view, you follow the data, you don't make it up. This is where the trials tested in cardiac surgery, 7.5, okay? And in orthopedic surgery, they tested 8, and those with pre-existing cardiovascular disease, which, by the way, there's not a lot of good, clear data on, we suggested an 8-gram threshold. Now, maybe the most important slide of the talk, most important slide of the talk is what we call a good practice statement. So in our guidelines, we say we consider it good clinical practice in deciding when to transfuse a particular patient to consider not only the number, not only the hemoglobin level, but also symptoms, signs, other laboratory results, and the overall clinical context. That is, you don't treat patients with a number alone. God forbid we go talk to our patient, we see how they're feeling, what their preferences are, what their vital signs look like, and then make a clinical judgment about whether blood is necessary in a patient and not just use a number. That is really what this says, and that's why I emphasize this over and over. Trials give you an average effect in a population, but individual patients have different physiology, different wishes, and different signs and symptoms, and you need to incorporate that in the way you choose to transfuse those patients. So I am almost done. We're going to go through these cases, okay? The 68-year-old person with COPD has a pneumonia on their x-ray, is sent to the MICU. Hemoglobin drops from 11 to 8.5. This patient would have been enrolled in the TRICK trial. They showed that 7 was as good as 10, and I agree totally with the audience here that I would use a 7 threshold unless there was something else going on in that case. Second case is an 80-year-old woman who's post-op with a hip fracture repair, has lots of cardiovascular disease, hemoglobin's 8.5 post-op. This patient would have been enrolled in the FOCUS trial. That trial showed that 8 was as good as a 10 threshold, and I would have waited till 8. Some people would wait till 7, as many in this audience did. I would just tell you, we have not tested 7 in this population of patients. And therefore, I think you should follow what the trial data says, but many would disagree with me on that. And then the third case is a patient with a STEMI that Mike Wong inserts the a stent into the LAD. The hemoglobin drops from 10.1 to 8.5, had a melanotic stool. So I'm going to ask once again, who's giving blood to this patient 8.5? Okay, a few more hands. Who's waiting till 8? Who's waiting till 7? So it's always reassuring to know that people don't believe my trial. Thank you very much. And so overall conclusions, the clinical trial data support the safety of restrictive threshold of 7 to 8 in most patients. In patients with acute MI, the MINT trial suggests the potential benefit of a liberal transfusion strategy of 10. I'll be happy to entertain questions. Thank you very much. Now we're going to have a panel. Okay, let's go panel.
So I was just talking to Will and some of the fellows. This is actually the first time I've heard this talk. I think many of them have heard it in prior grant rounds, but this is a terrific talk. I learned a lot today. Prior to coming up with the panel, I read up a little bit.
Thank you.
It's kind of updated myself on the current guidelines, interventional cardiology and cardiology. So my first question, I actually discussed with Will about this earlier. Our non-STEMI guidelines hasn't been updated since 2014 in the US. Europeans in 2020. So if you look at this little tiny paragraph that gives a class 3 indication for transfusions, Europeans have gone to 2B. Do you think it's about time for the US to kind of make an adjustment, upgrade it so that, I think a lot of us are probably remembering 8 because of that, kind of making it more of a higher 2B or 2A to think about.
Well, obviously, I think we should be using more liberal. I think this trial data says you surely should not let people stay low. And so I disagree with almost all of you that you should let them live at 7 to 8. I just think the trial data would suggest that that's not optimal. And will one trial affect guidelines? I don't know. We'll see. You cardiologists will make up your mind about that. There is more data coming. We have a meta-analysis, an individual patient data meta-analysis that's coming on that, and we'll see. Basically, I'll tell you what that shows. That's under review at a major journal, and we'll see if they wisely take it or not. And the relative for the primary of all-cause mortality or recurrent MI, remember the reality trial favored a little bit more restrictive. So the relative risk went from 1.5 to 1.3, and the lower confidence interval went from 0.99 to 0.97. So once again, not significant. But what's different in the individual patient meta-analysis, when you follow people out to 6 months, the curves remain parallel, with liberal doing better, and the p-value for that analysis is significant. Although the point estimate's still only 1.08. So I think there's evidence here that we certainly should avoid the real lows. Now, will that be enough to change guidelines? I don't know. It's one trial. It's clearly not definitive, and I'm not trying to claim that it is. It's kind of what we found. But I think the best evidence would suggest that it helps.
So I had a question. So in the clinical trials, particularly also in the NC, what's transfusion treated? I thought it was kind of seen as harm.
It's harmful. So
it's like it's a reportable.
It's a ding. It's a ding on your number. So so the NCDR. Just so everyone, I suspect most people in this audience know, but all your MIs and are sent to the NCDR data set. And when you do a cath, post-cath, if you get blood, that's considered harm. And the reason I know so much about this is because we had a whole bunch of sites that would not participate in the trial because the interventional cardiologist didn't want to take a ding for a trial protocol required transfusion. So it was a problem. And, we actually went back to the NCDR. We had a couple members of our executive committee were on that committee, and we got nowhere with them. And we got nowhere with them. I'll leave it at that. I don't want to say anything else that's not nice. Yeah, I was told, by the way, that the NCDR voted to remove that criteria now in acute MI based on the mid-trial results. I was really happy to hear that. Abel.
What happened with it?
Yeah. So we, this was a pragmatic trial. And what I mean by that is it's big, it's simple, and we collected limited data. We did not collect the type of stents or the number of stents that people got. We do have the anticoagulants that people were discharged on, and I don't actually remember what they are. They were comparable between the two arms, but I don't know what they are. So that's the best I can tell you. I'm sorry, I don't have more details on that.
2 components instead of 7, do we do 10?
Yeah.
People,
So I didn't show you the data on subgroups. When you look at the figure on subgroups, the relative risk for restrictive showing harm was 1.34 in type 1 MIs, and the relative risk was essentially 1.05 for type 2. In other words, no apparent effect in type 2, where it looked like most of the benefit was in type 1s. Now, the way you look at subgroups like that is you calculate what's called an interaction p-value. The New England Journal made us remove those interaction p-values, and they do that because there's a multiple comparison issue, and they know these are low-powered tests. However, as we go to secondary publications, the cardiology journals don't look at it that way, and the p-value for that interaction was 0.16, so not significant. So what I would tell you is that when I look at this data, and I don't know how Will feels about it, but to me it looks real that most of the effect was in type 1 and not type 2. And so if I had a type 2, I would be less inclined to transfuse those patients compared to type 1s. And the type 1s, if that ICU patient has a type 1, I would treat them like I just said. I don't know whether you would agree with that, Will, or not.
I think so too. The type 1s are, they've gone through the lab, just like Dr. Moore said, higher oxygen demand. I think less fun. Type 2 could be anything, and it could be anemia, chronic disease, or it really doesn't.
Yeah. So, what the reason we studied type 2s was, think about it. We have the underlying pathophysiology of supply demand, right? So it makes perfect sense that if an anemic patient has less supply and their demand is up, that giving blood might change that relationship, and that it made perfect sense that a type 2 MI might be benefited by liberal transfusion. The reason I'm hypothesizing why it doesn't work is you just have to think about who's our type 2 cases. They have a ton of different things going on. They have a lot of comorbidity. They're often really, really sick. And my view is that the reason we didn't see effect is because blood is kind of a minor player in the overall prognosis of those patients. And that's the reason we didn't see effect. But, once again, I don't have definitive statistical proof that you should treat those patients differently. And, at this point, my intuition is to treat them differently, but that's not what we're going to write, because the editors won't allow us to write that. We keep getting pushback. Well, it's not significant. And I'll point one other thing out, which is a statistical issue. If you look at the power of a test for interaction, and you compare it to the power for an overall analysis, you need 4 times the number of patients for a test for interaction compared to your primary analysis. So it's hardly surprising that you're grossly underpowered. And so the fact that we didn't find statistical significance, I think it's a hypothesis generating find. And for me, it's probably good enough that it affect the way I would treat patients, but I can't really say that definitively for sure.
So wondering from the point of view of mechanistic hypothesis that we could treat so something like, I'm just thinking about the methods of showing that cardiogenic tests are different that we could use. That has been actually, that's a very clinical trials, just because that is a very few such good therapies, not many people are trying, even with the mice. I wonder whether we should do a randomized trials.
Yeah. So, clearly a size of an infarct makes perfect sense. We actually have troponins. And so one of the ways that sometimes you measure infarct size is with your peak troponins. The problem is that it doesn't work in this trial because we did not systematically require troponins to be, we required it to be done for the first 3 days post-randomization, but the days that patients were randomized varied across the trial. 1, 2, is that the specific assay that was used at all the hospitals was different. Midway through the trial, we converted to high sensitivity troponins, and then there's all different versions of it. So we are going to look at that, and we've done some preliminary looks at it. The experts on our executive committee and steering committee, and Bernie Chapman is actually one of the people that prepared and is one of the authors of the third and fourth universal definition, didn't think that it was a high quality measure. And so but we don't have, we certainly didn't do MRIs. I mean, this is a highly simplified, pragmatic trial. And let me tell you, this was hard enough to do, yet to try to do MRIs, forget it, not going to happen.
A bit of a tangential thought as well. So from the advanced heart failure worldview, we show the potential risk of harm.
No, for potential benefit in this study. Transplant, okay.
Risk. And so I think an interesting study that I'm not sure has been done, and I'm not sure if it would be IRB approved, would be to know how low can you go in patients who are awaiting heart transplant. Well, we count a hemoglobin of 6.9, 6.8 if they're asymptomatic, because we're so afraid of sensitizing these patients who are about to get a heart transplant. So
Yeah.
I'm curious to your perspective on that, whether there's any data to support that, and as a corollary to that, there are some centers that are doing, for example, bloodless or transfusions in patients who are using blood products. Not just iron deficiency anemia, which we already do anyway, against heart failure. So they give them EPO to really boost up their own blood making mechanisms. So I wonder, again, with your expertise in this field, but I think it would be really interesting to understand how low can you go in advanced heart failure, and what is the actual data for giving all these EPO. I was just with Larry Uriel, and he was saying, I knew in Chicago we had very aggressive protocol for getting people's hemoglobin up without having to transfuse them, and it was protocol. I said, okay, great. Well, what is the data for that? We can do some type of study.
Yeah, so there's some studies that show that you can reduce blood use by using EPO plus iron. And there's also trials that show that if you use EPO and get the hemoglobin too high, that there's poor outcomes. That was demonstrated in renal patients. What there's not is any direct comparison between red cells versus using iron plus EPO. So that trial hasn't been done. I don't think it will get done, to be honest. And, in terms of, you're the transplant experts and about sensitization, how that's going to affect transplant. I don't have any expertise there. My understanding is, all the transplant teams prefer not to give red cells, don't want to do any pre-sensitization. And so, that's an issue that you have to try to balance.
People have shown the curve starting to separate at 10.
An early indication for what? Well, I think it all correlates. Okay. And to me, was one of the rationales of having a threshold of 10 grams was based upon the curves taking off at that point. I think we've proven with reasonable certainty, not 100% by any means, but if you have a 3,500 patient trial and you demand the 0.05 p-value, and I'm telling you it's just 2 cases to get there, do you really want to change how you practice? I don't think the answer should be yes in that situation. I think you should follow the guidelines. I mean, the data, and therefore I would argue that the witness data is perfectly consistent with MINT data. Now, the difference is those are patients that they don't have acute MI, they're any kind of underlying cardiovascular disease. I'll also digress by saying is that we don't have trials well-done trials just in patients with underlying cardiovascular disease to see whether liberal and restrictive behave similarly to the MI patients or to the other, or to the usual overall groups of patients who've been included in these trials. I think I have a new grant. It's an individual patient meta-analysis to look exactly at this group of patients, take all the different trials that have been performed, which now include like 25,000 patients, and stratify based on pre-randomization underlying cardiovascular disease versus not, and see whether liberal and restrictive makes a difference. So we hope in a few years to be able to answer that question more definitively than we have at this point in time. But to get back to your question, I think the witness data, correlates with what we found in MINT. Yes.
Recently, a big length of stay that in the heart failure ICU CCU setting, whether it's distribution, not discharge before, but death and laziness. Biological interplay between distribution rate, which is one of the highest features, actually the top one feature for predicting how we can actually manage patients here versus the
Yeah. I don't know that there's a biological reason. I would bet it's a chance finding. I don't believe it, to be blunt. I think it's a chance finding. You looked at a ton of variables and this one came up. And why would a differences in red cell size or volume predict outcome? I think it's a chance finding. It doesn't make any biological sense to me that I can think of. Sorry to respond that way, but that's what I think. Will, you have any other things you want to add?
Well, first of all, my conflict of interest is that we need to.
Yes, and I think things worked really well here, and it was because of Will. I mean, Will.
This was probably the two comments that I had. There are a number of papers coming on mid sub-studies, in particular the heart failure sub-study, and the type 1 versus type 2, where I think we find some interesting data. Getting back to cardiovascular death, although unadjudicated, it was such a strong signal that my guess is that was one of the components of what made the reviewers at the New England Journal like the study so much. But that I would give back to Jeff would be about the reviewers' comments and the editorial comments to the paper. When you have a large $19 million multi-center NIH-funded trial, have borderline significance. Usually people, especially and say, are ready to burn you down and say, this is nothing that you found here. And much the opposite happened. I've never seen anything like it. Actually did a statistical review to support the clinical importance of our findings. If you want to say something, I would even say, please read the comment.
Well, what Will's referring to is during the editorial process, we have these borderline results. I mean, they're borderline. And how should you interpret it? We from the beginning, our leadership team, including Will, we all thought that it looks like it's a real finding. And no, it's not definitive, but it looks like a real finding. And so what happened is we wrote it up that way. We got 5 reviews at the first review level from the New England Journal of Medicine. Okay. And 3 of them were very positive. One said, well, look, guys, it's not significant. Like, stop claiming it's a real finding. And the statistical editor of the New England Journal helped us shape the language as it is in the paper, because I think they bought the results. They bought the results that there was a meaningful, clinically significant improvement in patients with using more blood. And now I haven't been able to convince your colleagues here, you'll have to mark them down, by the way, because but just kidding. You're entitled to your opinions. So that's kind of what happened, and I would say we're getting a mixed review from from people, and I think your reaction about, it's not atypical. I mean, I'm seeing kind of a third, maybe up to 40% of audience, because I do this talk the same way, and I always present the cases up front, and most people who haven't read the paper are using an 8 threshold, and then I ask, like I did to you, how many, trying to see how many would have changed their mind, and there were a handful of you who changed your mind, but certainly not all of you, that's for certain, and but that's our evidence. It's the best evidence we're going to have. You're not going to have new evidence outside of our meta-analysis at this point. And I think the meta-analysis, especially with the long-term mortality differences, if you buy those results, then I think the logic of using liberal transfusion in this group is stronger. Thank you for having me. Take care.